excited to talk a little bit about our scientific statement on implementation science and cardiovascular health equity. So this statement really has been a project that's come out over the last couple of years. It's a team effort. We convened a working group to really think about some of the gaps in the literature. So it had been that, over the last maybe 2 or 3 years, there have been a lot of implementation science publications for implementation scientists, right? So focus on health equity, updating some equity frameworks, for example, as well as some publications for lay audiences, but without a focus really on cardiovascular disease or cardiovascular health equity. So our goal really was to provide a statement for a lay audience, for a clinical audience, to make it easier for people to actually infuse implementation science into their research. So this is really for people who didn't have a background in implementation science, were interested in doing this kind of research, were really interested in equity as well. So our goal was really to provide a roadmap for researchers interested in this area, and also synthesize some of the literature to date. So there've been a lot of research on evidence-based practices, implementation strategies, but there haven't been a lot of attempts to synthesize the data and really focus on historically marginalized populations. So we convened our work group, a really diverse group of individuals. I worked with Crystal Sine on this, and our group worked probably every quarter we met to really think about and define key concepts in the field. What is implementation science? What is cardiovascular disease equity? What are theoretical frameworks? We're really focused on defining everything, and then working to kind of build consensus as a working group of really diverse individuals. So we had epidemiologists and clinicians and implementation scientists, and also individuals with a background in health equity, maybe without a background in implementation science, for example. So we defined key concepts, we created a roadmap with key kind of equity considerations, and then really synthesized the literature. So some of the key findings that we presented, we created this 4-step process for conducting implementation scientists that anyone can really go through, really focused on identifying high quality evidence-based practices for people thinking about and still choosing the kind of evidence-based practice that they want to focus on. We really honed in on 3 areas. You should really be focusing on those that have an evidence to practice gap, but high quality in historically marginalized populations. Those increasingly we're starting to see some evidence-based practices that close disparities as well, and or target social determinants of health. This step number 2 is to really focus on determinants. We really focused on ensuring that people were targeting social and structural determinants of health and thinking about contextual factors in barriers to uptake of evidence-based practices. Number 3 was selecting, adapting, and using implementation strategies, again with a focus on specifying so that others can replicate what you're doing. So that's a real big goal in implementation science. It shouldn't just stop with the research, but our goal is to ensure that others can replicate our findings and other healthcare systems and policymakers can do the same. And then last, evaluate. So we really gave a checklist of how you can infuse different frameworks and theories in your evaluation component. So for every one of those steps, we had key equity considerations that you should be really thinking about for every step of implementation science. So this involved engaging stakeholders, including in the selection of your evidence-based intervention, involved infusing more theories and frameworks and models, thinking about rigor along every single step, thinking about social and structural determinants of health for every single step, right? So we really provided a checklist that anybody can go through. Our hope is that this will add rigor to the field, that this would allow us to have more shared language in the field so that we can share information, share data, more easily synthesize the data, and compare what works and what doesn't work in achieving cardiovascular health equity. Now I'd like to introduce Dr. Vela, who's going to be talking a little bit more about cardiovascular behavioral medicine and how to apply implementation science to the field.
Thank you. It's my pleasure to be here. This was put together in collaboration with the Society of Behavioral Medicine, which is really exciting that we're working together to amplify cardiovascular behavioral medicine specifically. So I'm going to be speaking primarily about clinical cardiovascular behavioral medicine, which is my area of practice, and how cardiovascular behavioral medicine, or CBM, can be better understood, can be better utilized in cardiovascular care nationally and perhaps internationally, and how it can really be an important opportunity for education and for expanding research, particularly implementation science, which we'll hear more about shortly as well. So cardiovascular behavioral medicine as a clinical area is a subspecialty of health psychology more broadly. So many of the folks who are practicing in this area are licensed clinical health psychologists. And our specialty is really working with folks to assess and address psychosocial and behavioral risk factors that are related to cardiovascular health and cardiovascular disease. So we have expertise in working with folks to address the essential 8, as well as other important risk factors. So we work with patients at individual levels, in group formats, in a variety of settings, cardiac rehab, inpatient consultation liaison, outpatient settings, etc., to help them improve their diet, to address sleep, to quit smoking, to reduce alcohol or other risky substance use, as well as to address anxiety, depression, stress, trauma, all of those psychosocial and behavioral risk factors that can play major roles in contributing to cardiovascular disease, as well as reducing cardiovascular health. And we have a really important opportunity to help folks improve their quality of life related to their cardiac health and more broadly. And so we, as clinicians, work with our patients to address some of these factors in a variety of evidence-based ways. We are, as licensed clinicians working in this area, we are able to bill, and what's important about that is that we're able to bill related to a cardiac condition, not a mental health condition. So we're able to support mental and behavioral health without needing to go to the mental health carve-out, which can really increase accessibility, and as well as potentially reduce stigma by having licensed clinicians who are a part of larger teams providing cardiovascular care who are truly integrated. We can increase access, reduce stigma, and help support patients to really live their best lives as they seek to reduce risk factors and engage in treatment for cardiovascular diseases. I'm now going to hand it over to my colleague, Dr. Gaffey, who's going to talk more about implementation science within cardiovascular behavioral medicine.
Thank you so much, Dr. Vela, and thank you for having me. So I am really going to be speaking to the intersection of both of the perspectives that you just heard. And within our research and our clinical findings, we've seen that there is ample, significant evidence demonstrating that there are a number of efficacious and very effective interventions that can be used to target the behavioral and the psychosocial factors, which we know are significant contributors to cardiovascular risk and to the onset of cardiovascular disease. And that these factors can be targeted in primary prevention settings, secondary prevention settings, and also in community-based participatory research settings as well. So targeting these factors is really central to the execution of the vision which you heard regarding effectively addressing those factors either individually or as a method of multiple behavior change. So we know that targeting these factors can be especially beneficial when considering a health equity lens and how to successfully address the health disparities that we see are incredibly prevalent among the patients and the populations who are most egregiously affected by cardiovascular disease. So when we think about implementation science and merging implementation science and those frameworks with cardiovascular behavioral medicine, there are many areas to target, and it may seem overwhelming to both researchers and clinicians, patients, as well as providers. So for a couple examples, we know that there's really significant evidence showing the value of addressing sleep in terms of reducing one's cardiovascular risk. Most recently, we've seen that cognitive behavioral therapy for insomnia specifically has shown to be very efficacious across a number of populations, including patients with heart failure. When thinking with a social determinants of health lens, that particular intervention has been translated very well to internet and digital-based platforms. So that may be one way in which that intervention could be better leveraged using implementation science to address patients and help patients who are perhaps in more rural settings. Other factors that may be beneficial to address with these types of frameworks could include depression. There have been many American Heart Association statements concerning the risk associated with either a diagnosis of depression prior to the onset of cardiovascular disease or following an incident cardiovascular event. And there has been significant research showing the benefits of cognitive behavioral therapy for depression or other types of evidence-based interventions for those populations. Another area of focus is certainly physical activity. We know that there's enormous work that has been conducted looking at various metrics of physical activity within individual subgroups of patients with cardiovascular disease and those who are at risk for cardiovascular disease. So certainly that may be an area that deserves more attention. Now, when considering an implementation science framework, we know that there are certainly many different dimensions, and it may seem overwhelming to a researcher to really approach implementation science if one has not worked in this area before. One of the most simple ways to think about this aspect of research is to perhaps consider what are the barriers that a patient is facing. What are the facilitators that may enable a patient to successfully enact enact processes to change behavior or to address their psychosocial health? And also from the provider side, what are the barriers that a given provider or subsample of providers may face in terms of being able to offer the appropriate health care and the appropriate services to their patients? So just with this simple question, one can start to see how you can step into the implementation science space with your research hat and then also from the clinical perspective.
So thank you so much for joining us. EPI 2023 has really focused on implementation science, and we hope that this conference will be a springboard for novel implementation science to achieve cardiovascular disease equity, particularly as it relates to behavioral health. So you've heard a lot of really important evidence-based interventions around CBT and insomnia. We heard a lot of talks around sleep, and so there are a lot of evidence-based interventions for these key risk factors for cardiovascular disease that contribute also to disparities. And so our hope, it really is that we'll spur research in this area and close the evidence to practice gap and reduce disparities by 2024.